todos ustedes y también a los que se están viendo a través de nuestro canal de YouTube, que es bastante gente por lo que estoy viendo en las redes sociales. Sin más preámbulo, pues continuando con el programa el día de hoy, tenemos la presencia, lo comentaba hace rato, voy a dejar en manos del doctor Luis Alcocer Díaz Barreiro, quien es maestro distinguido, fundador de este grupo de expertos en hipertensión, sin duda un líder a nivel nacional y en Latinoamérica, sobre el tema que nos presente a nuestros invitados de honor el día de hoy, sobre este simposio Satélite, y también agradecer en este caso a Servier, quien nos hizo favor de patrocinar este evento. Y bueno, doctor Luis Alcocer, adelante por favor y bienvenidos. Muchas gracias.
Muchas gracias, querido Héctor. Muy buenas tardes, buenas noches a todos ustedes. Gracias por permanecer con nosotros. Y la noche de hoy debo agradecer pues, a GREHTA en primer lugar, a nuestros amigos de Servier por hacer posible este simposio, en que contaremos con la presencia de dos distinguidísimos profesores. El profesor Kreutz, él es farmacólogo clínico y es expresidente de la Sociedad Europea de Hipertensión. El doctor Stergiu es actualmente el presidente de la Sociedad Internacional de Hipertensión. Hablar de ellos es muy difícil, sobre todo pues son investigadores de una gran calidad y han aportado muchísimo a la hipertensión arterial en el mundo, al conocimiento de la hipertensión y a su práctica. Y el día de hoy vamos a revisar pues fundamentalmente una propuesta que hace la Sociedad Europea de Cardiología en relación, de hipertensión, a cómo debe manejarse la hipertensión desde el punto de vista de un protocolo muy lógico y establecido. A mí voy a hacerles, no está el clicker. Perdón. Una pequeña introducción sobre la situación en México. La enfermedad cardiovascular en México, como en muchas partes del mundo, es el líder de inmortalidad y en México mueren 192.518 personas al año por enfermedad cardiovascular. Como la ven, es el primer lugar sobre la diabetes y los tumores malignos, y de estas, el principal factor de riesgo al cual se le puede atribuir esta mortalidad, o que está atrás de esta mortalidad, es la hipertensión arterial. Tenemos mucha información sobre hipertensión arterial y lo que más nos preocupa es esta cascada en el cual los pacientes se van perdiendo en un camino que no les permite alcanzar la meta fundamental del tratamiento, que como les hemos mencionado, insistimos en mencionar, es el alcance y sostenimiento de una meta de presión arterial, actualmente todos de acuerdo que sea alrededor de 130-80 por el resto de su vida. La prevalencia en México, si tomamos en cuenta el criterio de la American Heart Association, es de 47.8%, y si tomamos el criterio clásico de 140-90, 26%. De esto depende de las muestras y depende pues de la edad de las muestras. Esta información proviene fundamentalmente, en nuestro caso, de las encuestas nacionales de salud, que son unas encuestas probabilísticas extraordinariamente bien hechas, y además de una información muy importante que tenemos sobre el mes de mayo, mes de medición internacional, en que hemos aportado una gran cantidad de personas mexicanas. De tal manera que la información que tenemos sobre México es una información muy sólida. Hemos mejorado bastante en lo que se refiere a la detección. 65% de los pacientes mexicanos saben que son hipertensos, y esto es importante, 52.3% reciben tratamiento. Pero el problema fundamental actual en todo el mundo sobre la hipertensión arterial, que depende mucho de nosotros y que es lo que queremos cambiar con que ustedes hagan un enfoque correcto de la presión arterial, es que de los pacientes que están recibiendo tratamiento en México, solamente 33.5 están controlados. O sea, quiere decir que en realidad es la mitad de los pacientes que están tomando su medicamento, porque esto lo vimos en la encuesta nacional de salud, se hicieron preguntas y se midió bien la adherencia, pues la mitad de los pacientes que están tomando medicamento, que se lo toman, no están en meta, y esto depende fundamentalmente de nosotros. ¿Y a qué se debe? Bueno, pues fundamentalmente que nuestros niveles de monoterapia todavía son exagerados. Ya sabemos que solamente la monoterapia es capaz de controlar, pues cuando mucho, a 1 de cada 3 pacientes con hipertensión arterial, y la monoterapia en México es todavía alcanza 37.9%. Aquí ven la distribución de los tipos de tratamientos. Y el problema en México, como en todo el mundo, es que en realidad no existen hipertensos puros. Esto proviene de nuestro registro de GREHTA, y vean ustedes que solamente menos del 1% de los mexicanos viven solamente con hipertensión. La mayoría de los mexicanos viven con 3 a 4 factores o 5 a 6 factores. Fíjense que más de 3 factores lo tienen el 70% de los mexicanos. O sea, el ver la hipertensión arterial como algo aislado, pues es auténticamente una barbaridad, puesto que la mayoría de los pacientes mexicanos, pues es en conjunto. Entonces, y otro de los problemas fundamentales en nuestro país, y también no es diferente de muchas otras del mundo, es que el riesgo medido, el riesgo cardiovascular medido promedio del mexicano es del 12%. Esto quiere decir que la mayoría de los hipertensos mexicanos son hipertensos, tienen de 2 a 3 factores de riesgo más, y la mayoría, prácticamente todos ellos, son de alto o muy alto riesgo. Unos cuantos de mediano y prácticamente nadie de bajo riesgo. Entonces, la idea fundamental es que cambiemos esta situación, porque como les decía yo, esto proviene de problema de inercia. Fundamentalmente, además, el 83% de nuestra población es con sobrepeso u obesa. Es más que la población general. En la población general esta cifra es 75%. El hipertenso mexicano es 83% más con sobrepeso, obesidad. Y otro de los problemas muy importantes es que el 87% de los mexicanos que viven con hipertensión tienen trastorno de los lípidos. Y solamente, por ejemplo, el 22% de ellos están tomando una estatina. Esto es algo que revela que no estamos entendiendo el problema. Que si el señor es hipertenso, pues lo único que nos preocupa es la hipertensión arterial y no los otros factores de riesgo. 12.4 de los pacientes, a pesar de ser alto riesgo, están tratados con estatinas, y sin embargo, por ejemplo, el 22.6% están tomando aspirina, que es muy difícil justificarla en pacientes en prevención primaria. O sea, aquí hay una idea no clara sobre cómo entendemos los médicos mexicanos al paciente hipertenso mexicano. Por eso la necesidad de que tengamos una idea más clara de esto. El simposio se va a desarrollar de esta manera. El doctor Martín Rosas, quien saben que es una gente muy importante en GREHTA, será nuestro próximo presidente, va a presentar un caso clínico de un mexicano típico. Y después los profesores invitados van a hablarnos sobre cuál sería la manera correcta de manejar este tipo de pacientes. Martín, por favor.
Buenas noches. Gracias por estar aquí después de un largo día académico, y veo que la asistencia continúa. Eso habla muy bien de Campeche y de sus deseos y de estar ávidos de tener actualización en su conocimiento. Como ya se señaló, me tocará presentar un caso clínico, y tenemos, de verdad, nos sentimos muy honrados de la visita de dos profesores que son extraordinarios. Su currículum verdaderamente resumido al máximo está en esta diapositiva, porque ambos son profesores de tiempo completo. El doctor Kreutz es farmacólogo, hipertensólogo, es director del Departamento de Farmacología Clínica. Él está en Alemania, en Berlín. Y él fue el pasado secretario del 2017 al 2019 y presidente de la Sociedad Europea de Hipertensión. Él fue coeditor de las guías de hipertensión arterial de 2023 y de esta fuerza de tarea en el 2024. De manera que, gracias, thank you very much, doctor, to be here. And the second, el segundo profesor que tenemos es el doctor George Sturgeon. Él es de Grecia, ¿no? Recuerdo una frase de upa, ¿no? en Grecia. Y bueno, él es, además de una gran persona, es presidente de la Sociedad Internacional de Hipertensión en los últimos 2 años. Igual tiene un centro de hipertensión, él es jefe de Escuela de Medicina en Atenas, muy reconocido y muy querido además, porque además de ser un gran profesor, es un gran ser humano, como pudimos constatarlo hace un rato que platicamos con él, con ambos, que tienen ese cariño por querer enseñar. Ambos no hablan español, obviamente van a presentar en el idioma inglés, y bueno, pues les agradecemos mucho. El escenario ya lo mencionó, no lo voy a repetir, ya lo mencionó el doctor muy bien, el doctor Luis Alcocer. Van a ser estos escenarios, esa es la dinámica. Y entonces vamos a ver un caso clínico que espero les traiga muchos recuerdos. Se llama Juan y todos hemos tenido un Juan, ¿sí? Juan es un enfermo que, como ustedes ven, tiene 58 años de edad. Él dice estar asintomático, aunque van a ver que cuando uno le pregunta no está tan asintomático. Exactamente, tiene sobrepeso con un índice de masa muscular, con un índice de masa corporal, perdón, de 29. Y bueno, la presión en el consultorio anda alrededor de 150-90, su pulso en 85, y era visible el edema al entrar al consultorio, como tantos que vemos nosotros todos los días, ¿no? Este paciente, se le hicieron sus estudios de laboratorio. Él básicamente, su única queja es que sentía que se fatigaba un poco más que de manera cotidiana, pero prácticamente asintomático. Sus laboratorios ahí están, las enzimas hepáticas un poco elevadas, su filtrado glomerular, bueno, en 80, su LDL en 160, la hemoglobina glicada en 8.1, y le habían mencionado los diagnósticos de hipertensión, diabetes y de enfermedad en el hígado. En realidad, a la hora de revisarlo desde el punto de vista de exploración física, pues no había grandes datos más que los que ya mencionamos, ¿no? El paciente se presenta para una evaluación médica de rutina, necesitaba un certificado para su trabajo, no había mencionado, no tiene historia de hipertensión, les decía, reporta un poco de fatiga y sobre todo al subir escaleras rápidamente, dice, solo cuando subo las escaleras rápido me fatigo, si no, no. Pero, ¿y cuando sube las escaleras? Pues casi no, ¿no? Ese era el punto. Y luego, en su pasada historia, dice que diabetes mellitus y que él prefiere un tratamiento alternativo, no sé si le suena conocido acá, donde los pacientes usan mucho el tratamiento alternativo, en este caso le gusta tratarse con nopal, él le tiene mucha fe, y bueno, él prefiere ese tratamiento. Para la dislipidemia toma atorvastatina, pero lo hace de manera irregular, no es constante en el tratamiento, y previamente le dijeron que la presión estaba alta y le habían indicado algún tratamiento, pero tiene una muy pobre adherencia y bueno, pues él insistía en que realmente no se sentía tan mal. Ahí están las características que ya hemos mencionado, sobrepeso, la presión arterial elevada, sí tenía historia de tabaquismo, además dice que le daban metformina 1000 al día, losartán 50 miligramos, que a veces lo tomaba, a veces no, la torvastatina, pero con una adherencia muy, muy irregular. Él prácticamente, a lo que iba es que le dieran su certificado, ¿no? Y bueno, evidentemente la acantosis, pues ahí está, ¿no? El edema periférico ahí está. Y bueno, con estas características y aparentemente sin ninguna otra alteración, pues uno pensaría que en términos generales, bueno, pues es un paciente diabético con hipertensión y aparentemente no tiene más nada. Pero si uno le empieza a rascar un poquito, las cosas de factores de riesgo y etcétera se van acumulando. Entonces, aquí están sus exámenes de gabinete. El electrocardiograma pues habla solo, una hipertrofia ventricular izquierda bien puesta. La cardiomegalia creo que no deja duda. Y pese a que él decía que no sé, las enzimas hepáticas y la proteinuria que se hizo con una tira reactiva muestra 2 cruces, que es un equivalente más o menos a 30. ¿Sí? La LDL en 137, HDL 32, triglicéridos en 172, su glucosa en ayunos de 24. Entonces, este es el caso que no vamos, we don't have to analyze the specific case, only is use it as an example for the master plan that the professors nos van a dar, ¿sale? Entonces, es un ejemplo nada más, no se trata de analizar el caso, sino cómo lo abordaríamos desde el punto de vista con master plan, que esa es la propuesta. Entonces, le pediría a nuestro primer ponente, perdón. Ok, if you can come please, both of them. Entonces les decía que en la primera, bueno, antes de que nos tiren, vamos a pedirle al doctor Reynold Cruz que nos aborde la primera parte y posteriormente al doctor Sergius la segunda parte. Okay.
So, ladies and gentlemen, thank you for the invitation to visit this wonderful city. It's my first visit to Mexico, and I see you have a lot of good reasons to come here. I'd like to congratulate the GREHTA organization, particularly for collecting information on cardiovascular risk factor and disease in your region. Because only if you know what's happening in your region, you can tailor the recommendations according to what is needed in your population. So I'll start by presenting you the European Society of Hypertension guidelines. You can see on the left, it is a long document, 200 pages, almost 2,000 references. It is a valuable source of information for anybody who wants to find details on hypertension. These are European guidelines, and you can see these are endorsed also by the International Society of Hypertension. But on the other side, you can see the practice guidelines, and this is what is needed for primary care. So here is the source of information. Here is the guide for clinical practice. And these practice guidelines have 4 elements, 4 steps. And the first one is the blood pressure measurement. We often take blood pressure measurement very lightly, but there is no other way to find who has hypertension, who needs 1 drug, 2 drugs, 3 drugs, no other method. So the European Society of Hypertension, you'll see that puts a lot of emphasis in accurate diagnosis, which is the first important step before doing anything else. Of course, we have the classic measurements of blood pressure in the office, and we have the classic thresholds. I noticed that you discussed the American threshold, which is very close to your country, but this is American only. All the other world uses this threshold for diagnosing hypertension. And we have home measurements, which are widely used in many countries, and they have a lower threshold, and we have 24-hour ambulatory monitoring, which is not available in most primary care settings. It is supposed to be the best tool we have today to diagnose hypertension, but it's not widely available. So these two out-of-office measurements have lower thresholds for diagnosing hypertension. Whichever method you use, single measurements have no value. All methods should be based on average of several visits, 2 or 3 visits with duplicate or triplicate measurements. For home, 3 to 7 days. For 24-hour average of all readings, 24-hour daytime and nighttime. So average blood pressure, look at profiles of measurements rather than individual readings. And there are specific recommendations. The important message here is casual office blood pressure is not appropriate for diagnosing hypertension. A measurement in the office is nothing unless you use the proper methodology, the proper conditions, the proper protocol, an accurate device, and the right cuff for the arm of the individual. Office blood pressure is useless. So casual blood pressure in the office is not for hypertension diagnosis. Only standardized methodology can be useful for diagnosing hypertension. And you can see here, again, for home measurements, the same case. You have to standardize the methods. You have to fix, to keep the protocol, duplicate morning, evening, at least 3 days, discuss the average, use a validated upper arm cuff device. Then the methods can be diagnostic for hypertension. And there are also recommendations for how to use ambulatory monitoring, which is occasional and in the settings where it is available. How many of you do you have access to 24-hour ambulatory monitoring? Raise your hands, please. The experts in the beginning. But most of the hypertensive patients are in primary care. So ambulatory monitoring is never going to be a solution for most patients, at least in the form that it's available now. So for the measurement, the European Society of Hypertension puts a lot of effort in accurate diagnosis. In fact, it is the society in the world that published the most guidance for technology and methodology for blood pressure measurement. It is emphasized that only validated electronic devices which have a cuff at the upper arm should be used for all methods. And for each method, the standardized protocol should be used. Office blood pressure measurement is the basis. Home blood pressure measurement is the ideal method for long-term management, monitoring of treated hypertension because it also improves adherence with treatment. 24-hour ambulatory measurement is the best tool, but as I said, it's not widely available. So for our patient, we saw a number, 150/90. How many measurements? Which device? Which cuff? Were there measurements out of the office to confirm whether there is white coat hypertension, mass hypertension? We don't know these details. But what we know is that it's a 58-year-old guy with diabetes, hypercholesterolemia, fatty liver, 90% chance to have hypertension. But still, for the individual, you have to confirm with proper methodology. And remember that diabetics have a lot of mask hypertension and nocturnal hypertension. So it's important in this patient to have particularly home measurements, also because there is indication that he has low adherence with treatment. Thank you very much.
Buenas noches. It's a great pleasure and honor for me to be here. I like also my new shirt. Thank you very much for this. I hope it's not embarrassing for you to see me in this shirt. So when we designed the master plan, of course, we tried to find the acronym. So the M is the measurement, of course, is easy and to diagnose, you know, as Professor Sterju mentioned this, the first pivotal step. And then the next one is the A in the master is the assessment of the patient, what can we do? And I would like to discuss, introduce the second step or pillar, as we call it. And look at the icons. We used intentionally also these icons. I come back to this. What you see here, I come back to this also. We try to highlight what can be done. And then in the master plan, as you have seen for the blood pressure, and we have together with Professor Cammerfort from Barcelona and Professor Enrique Rodilla from Valencia, we have translated into Spanish and it can be adapted. So we will provide it very short time for you. It's more or less ready to go, this master plan, and we have this infographics, quite busy. And I just want to select some specific items. At the very beginning, of course, we can argue what has to be done as an essential basic assessment on almost all patients. And I would like to focus on this. So when I talk to, and you would ask me to the students, even when teaching, I said, okay, for treating hypertension, not overall cardiovascular in the whole patient, but talking only about hypertension, what I essentially need is definitely a potassium. I cannot imagine to do anything without a potassium. We need the EGFR for any treatment, and specifically also for hypertension, not also for nephrologists. We need also the urinary albumin creatinine ratio. And the only technical methodology or further assessment we recommend as essential, because also the question is what is available. Of course, you can do an MRI, but what is essential is maybe potentially the ECG. So, or EKG is a German abbreviation. So, you know, lab tests, you have several, of course. For the risk, we need lipids, we need LDL, non-HDL cholesterol. It's very important, you know, to use the treatment also for lipid-lowering therapy and the parameters I mentioned. So I don't want to go to all the details, you can read it, but I just want to highlight, for the sake of time, also some important issues. So as highlighted on the right side, urine, we should always look into the urine. There was a dipstick analysis in our patient, it was already positive. But if it's negative, it doesn't exclude the possibility that the patient has albuminuria. And we need to have a specific assessment. We recommend, and I know it's difficult to implement. We did a survey on this, is the urinary albumin creatinine ratio. Even in hypertension specialists in Europe, the adoption is not that high. And also you can do a multi-component dipstick, what has been done in our patient. Martin presented so nicely. Why do we need urine analysis? EGFR, you know, we need it for selection of the diuretics, we need it for the selection of RAS inhibitors, you know, and other drugs, but we need it also together with the UACR to classify chronic kidney disease according to KDIGO, as you see. So you can grade it according to this, and we know if you have severe or advanced chronic kidney disease, you are at very high risk immediately already, you know, with or without diabetes, you are at very high risk, not only for the development of end-stage kidney disease or advanced kidney disease, but also for cardiovascular disease. So we need this, and that's the reason why we put already on the assessment also as an icon, you know, the urine sample together with the EGFR. So the other aspect what we see should be integrated in the basic assessment is ECG. Because with the ECG, we have the resting heart rate, you know, if the heart rate is, the resting heart rate is documented, of course you can take it also with the pulse, but if you have a nice resting ECG, We have the resting heart rate. If we consider that the resting heart rate is higher than 80, it's considered as a surrogate for increased sympathetic activity, and also maybe the differential therapy in terms of beta blockers, yes or no, could be guided. We need an AV interval if we use a beta blocker, and even though the sensitivity is not high, but the specificity is quite high, we can already, in some patients, we can see LVH. The future, we know from the Mayo Clinic and others, and there will be a lecture tomorrow about artificial intelligence and modern technology by Professor Sterju. We know now we can, just looking at the ECG now and in the future, predict many things, cardiovascular things, and already also the potential risk for heart failure or HFpEF. So ECG, I think, should be a basic assessment in all our patients, and now and in the future even more so. So that's the right way. We created a master plan, and this is just an example I would like to highlight. Of course, we can do extended, depending on whether or not it's available and whether or not it has an impact on management. You know, I do not do an investigation in my patient if it doesn't have an impact on management. I wouldn't do it. You know, I wouldn't pay for anything that does not have an impact on management, either for risk prediction or for the selection of therapy. Otherwise, we should not do that. So, but we have a list, and we have detailed this in the full guidelines, but also in a short form in the practice guidelines. And also what we included is also, when I go back, we included also, I come back to this also, when to refer a patient to a specialist, and some in situations, conditions, when to refer as an emergency to the hospital. When it comes to this a referral to a specialist, for instance, we may also think about secondary hypertension. So the question is whether we see now, even in children, I've learned from you that obesity is like 70% in children, adolescents, also in your country. So you can consider that this is also a form of, now the most common form of secondary hypertension. But of course, the old classical rare diseases, they have also some age dependency. So therefore, depending on the age of presentation, we may consider also the presence of secondary hypertension and the likelihood to have secondary hypertension as a cause. Therefore, we included also this as a guidance in terms of assessment or referral to specialists, the age dependency of hypertension. And then, of course, the referral, as I mentioned, we included this into the assessment, which is important to differential strategies. Okay. Finally, which does not apply to your case, Martin, but of course for completeness, we also included, and we are very grateful, another Greek guy we have in the council. We are very happy. It's a Greek-French guy, Athanase Benetos. He's now working in Nancy. He's one of the key opinion leaders in geriatric medicine, I would say, in hypertension. And he is leading the working group of patients, older patients in hypertension. And we also included a stratification according to age, frail patients. I just want to mention, for completeness, there's also some guidance in our guidelines how to assess the physical, the functional capacity and the mental capacity. And depending on the status, you know, the age, the calendar age is not so important. If the patient is old and fit, we consider to treat, even though the evidence is not that strong, as a younger adult. If the patient is severely dependent on the right, of course, we individualize, and we are very cautious with treatment. And if somebody, like in medicine, if somebody is in between, we have to decide what to do. And we have some guidance also how to assess older patients in terms of functional status and mental status included in our practice guidelines. For this, I would like to end the second pillar, and I think, Martin, you catch up now with the case, and then we'll continue with the third and the fourth pillar. Thank you very much. Muchas gracias.
Thank you very much, Doctor. I think it was a very clear and nice presentation. Déjenme mostrarles las siguientes diapositivas en orden de lo que uno haría en este caso. Si uno ve este caso, llega a tu consultorio, evidentemente tú ya identificaste el sobrepeso, el edema, la presión arterial elevada, el electrocardiograma, la radiografía de tórax. Ya tienes un panorama general muy claro de que Lo único que no es este paciente es de bajo riesgo. Es decir, lo único que no puede ser es que sea de bajo riesgo. Es un paciente que de entrada será de riesgo moderado alto o muy alto. Y de acuerdo al perfil que estamos viendo, el paciente tiene presión arterial no controlada, tiene daño a órgano blanco, evidentemente, ¿sí? Digo, el corazón, el electro, aunque la función renal, por ahí está Silvia Palomo, que es we have a nephrologist that is very criticism about this. But, entonces, yo entiendo que el problema renal, en este caso no tiene problema estadio 3A, lo habíamos puesto con daño renal, pero lo quitamos para... evidentemente tiene hígado graso, fat liver, y definitivamente, si yo veo este caso, sin ninguna calculadora de riesgo que yo quiera usar, solo con el análisis clínico crítico, este es un paciente de alto riesgo. ¿Sí? Las calculadoras de riesgo para pacientes que son de muy alto riesgo no tienen utilidad. Es decir, el paciente es de muy alto riesgo, sí o sí, con o sin calculadora de riesgo. ¿Sí? Aquí este es un abordaje muy importante. Por eso la historia clínica es fundamental para poder hacer el abordaje de este tipo de pacientes. Entonces, este paciente definitivamente, de acuerdo, obviamente en Europa se usa ajustado a la edad para ver el riesgo, pero este paciente definitivamente tiene más de 3 factores de riesgo, su presión arterial está en grado 1, tiene daño cardiovascular o insuficiencia cardíaca que ya lo pone como un sujeto con daño a órgano blanco importante. Es un paciente de alto riesgo, de muy alto riesgo, ¿sí? De acuerdo a la evaluación. Tiene hipertensión, tiene dislipidemia, tiene diabetes, tiene insuficiencia cardíaca y el daño renal, aunque no está muy marcado, se tiene que investigar, ¿sí? Definitivamente, velocidad de filtrado glomerular no es el único factor para definir si un paciente tiene daño renal, por favor, ¿sí? Entonces, en este sentido, sería la explicación. Y bueno, vamos a continuar para que nos oriente en la parte final del análisis. Doctor.
So let's move to the action. This patient has obvious, very high cardiovascular. He doesn't need any calculation. He is a cardiovascular bomb, which means you give him an appointment in the next month, and you don't know whether within these 4 weeks he is going to have a cardiovascular event. It's very important to identify because action is urgent. So, lifestyle is for everybody. High risk, low risk. Some people will go only for lifestyle sometime, but even those with high risk will benefit not only for blood pressure, but also for cardiovascular factors. It's something we neglect. It's something which takes time, and it's something we should be doing in every visit in the office. This case is the case where you start immediate treatment, not only for blood pressure, but for anything which is treatable. And you need to have a plan. The patient should know, and you should agree with the patient. The patient should accept what is the target blood pressure. So as soon as you have agreed with the patient on the target, you have a fixed plan. See him every month, aim at reaching blood pressure control for blood pressure, and anything else which is modifiable as soon as possible. These are useful only for those people where the risk is not visible. Not in this case, you don't need that. But in some cases which seem to be at low risk, this risk calculator is important. So lifestyle modification needs a separate session. You need to look at this slide carefully. There are new information about sleep, about diet, about exercise. We have changed our recommendation, and we need to spend time to get the benefits for each of our patients. And of course, some people with high normal blood pressure who are at low risk can stay with lifestyle modifications alone. So for treatment, you can see at the top the renin-angiotensin system blockers, ACE inhibitors, or angiotensin receptor blockers. They can be combined with a calcium channel blocker, dihydropyridine, or a diuretic. And beta blockers can be used at any stage if there is a special reason. And you can see here, for the vast majority of patients, you have to start with fixed dose combination. This is a problem which was visible in the data presented in Mexico. Many people start on monotherapy, particularly in these very high-risk patients we discussed today. Starting with two-drug combination is vital. And in this case, I wouldn't spend too much time looking at out-of-office blood pressure, mass hypertension, white coat hypertension. These are meaningless for a very high-risk patient. So you up-titrate to maximum dose, tolerable, and then you go to 3 drugs. You prefer to give a simple regimen. You prefer to give as much as possible all drugs in one dose in the morning or afternoon, any time of the day, which is convenient for the individual patient to take it regularly to improve adherence. And of course, simplification means that you give one pill which has 1 drug or 2 drugs or 3 drugs, and soon with 4 drugs. For some patients, this is very important to improve adherence. And this is the stepwise management. You can see start with dual dose combination for most patients with a RAS blocker plus a calcium channel blocker, dihydropyridine, or a diuretic. At this stage, you have controlled 6% of your patients. And then you give the 3 drugs altogether and reach the optimal control in almost 90%. And then you enter the section of resistant hypertension. You can see here on the right, you can use beta blockers at any time if there is a reason. And there is a list of hard indications and soft indications where a beta blocker can be useful for an individual patient. And you can start with monotherapy, but this is not the rule, it's the exception. And this is something that you should change in this country. If you have a low-risk patient and blood pressure is a little higher than the threshold, you can go with monotherapy. When you treat high normal blood pressure in patients with high risk, then you can go with monotherapy. And of course, you have to go progressively with monotherapy in frail people or very old people. But otherwise, the rule is 2-drug fixed dose combination. I think you saw that. As I explained, it's important when you start treatment to discuss and agree with the patient what is the target blood pressure, and then do whatever you do and as fast as you can to reach this blood pressure goal. And you can see here, these are goals for office blood pressure. The green is the goal, and the dark green is somewhere over 120. So 125 average office blood pressure and similar levels for home blood pressure is the optimal systolic blood pressure goal, and between 70 to 80 for diastolic. Of course, you have to individualize these goals in people who are frail or very old. And now, moving to the last step by Professor Kreutz.
Now, the last one is follow-up. We usually may say in clinic follow-up. I don't know what you use in Spanish, but so it doesn't fit with the master plan. So we used ER, evaluate the response. So we look at the blood pressure, but we also look at other parameters. And we have another infographic summarizing everything. So very busy slide. I just want to touch upon some points. First of all, I would like to mention there is almost no strong evidence how to follow up. So this is expert opinion. You know we have evidence for how to treat, which are the targets. Now we have evidence how to measure the blood pressure, but how to follow up is more or less expert opinion, and of course it can be individualized. What we did actually, we looked at the parameters which are important to follow up. Of course, we have the visits, we have to measure the blood pressure, and I think the key take-home message here is from Professor Sterju is to home blood pressure measurement would be very, very important if possible in follow-up. It has many aspects where it is so important, and ambulatory blood pressure is not available, and it's not the optimal method, at least with the technology available right now, as he suggested. And when we look at lab tests, of course, we look at potassium EGFR. It's very important. I can only repeat, and also some other parameters. And depending on the presence and the presentation, we can argue when and how to look at organ damage in your patient. And very, very important in the future is now is to address adherence, and also team-based care, I think, also to support the patient in a network. For instance, in Germany, we have actually not the German Society of Hypertension, we have the German Hypertension League. And the German Hypertension League, because we termed it league, so from a legal point of view, in the league we can include patients. In a scientific society, it's not in Germany, it's not allowed in Europe to include patients. So we have patients included in the society, and we have networks where the patients also group together and teach each other and support each other. And also, of course, novel technology, digital technology will be important, virtual visit, etc. So we have to try to have the initial phase 0 to 3 months. There is some evidence, and that's the reason why we also, for the follow-up, we recommend to try to target the blood pressure already within the first 3 months, particularly in high-risk patients. Your patient, we know from the value trial, other trials, that they have already events. So that's the reason we have evidence for this. But for the rest, for low risk and what to do, it depends really on the individual patient. So we have only some expert opinions in our infographic included. We should optimize the blood pressure after 3 months to 12 months and control as soon as possible. Also to use the different technology, home blood pressure measurements before any visit. As Professor Sterju mentioned, at least 3 days or 7 days, ideally, before a visit. It can be a virtual visit or a real visit. Proper home blood pressure measurement readings taken together gives a very, very good result that can guide our further management. And also depending on the organ damage. Of course, we cannot expect that left ventricular hypertrophy will change in a couple of weeks. It needs some time. Albuminuria also needs some time. Maybe it's more rapid in terms of response. We can discuss with Sylvia whether or not when to look at this, but of course, and we can look into this. And then we build a nice ecosystem, hopefully within 1 year, let's say, and do these aspects. I don't want to mention this because I think we should have some time for the final discussion. And at the end, depending on the risk, really, what to do if you have a very low risk patient, very well controlled, you can of course ease and relax more as compared to your patient that needs more a strong follow-up also long term, and which is important. And very important at the bottom, we need to find a way to maintain patient support with team-based care. I don't know, for instance, also we have some research projects also ongoing and also including pharmacists, into management and patient support. Sometimes, even to do proper blood pressure measurement, it will help also. So that's just one aspect at one end of digital technology that we have in the future. So with this, I would like to end. I think we should now discuss some aspects of the patient, what applies to our case in terms of follow-up and also the selection of therapy, etc., that can be done. So maybe we join us here at the podium. Yeah, please.
Ok, muchas gracias. ¿Tenemos tiempo para alguna pregunta o comentario que quisieran hacer sobre el abordaje de máster? Ah, sí. Que si le ponen una silla a mi máster, con cuidado, cuidado, cuidado. ¿La ves? Ya. Ok. I'll continue. Ok, entonces, si tienen alguna pregunta o comentario, como ven ustedes, el programa Master Plan es un programa que trata de abarcar todos los aspectos en hipertensión, no solo milímetros de mercurio, sino te lleva a tratar de siempre abordar. Nosotros, we have in the GREHTA group a very similar program that Master that we call the Macarena. Macarena is a program that we have in order to remember that hypertension doesn't live alone, because hypertension alone is very rare in Mexico and in the world. Yeah? So we try to keep in mind that the hypertension lives into the several chronic disease, and you need to approach all these chronic disease and the characteristics of patients, because if you only try the millimeters of mercury, you don't have exit in these patients. ¿No? So, por lo tanto, si tienen alguna pregunta, acá el profesor Pierscott, con mucho gusto. Si le pueden acercar un micrófono al profesor. Allá. Adelante.
Thank you for the nice presentations, excellent presentations. This patient is type 2 diabetic. In these cases, nocturnal masked hypertension is most frequent than in general hypertensive populations. How do you work with the diagnosis of masked nocturnal hypertension, and how do you treat in cases that you find out this phenotype? It depends who is asking the question. If we are in an academic discussion, I would deal with nighttime blood pressure. I think nighttime blood pressure is, in this case, it's a lost opportunity. This patient is at very high risk. I wouldn't care about nighttime blood pressure. He needs aggressive reduction of overall blood pressure and all the other cardiovascular risk factors. He has 10 things to do. Reduce office blood pressure and home. In my opinion, home blood pressure is the center for diagnosis. He has to deal with diabetes. He has to deal with hypercholesterolemia. He has to be investigated with heart failure. I don't know if he has coronary heart disease. I think discussing for nocturnal hypertension for this patient is losing the target. It is very minor for this patient. It is an almost academic, because even if, let's say he has nocturnal hypertension, how are you going to treat it? We don't know. So this patient needs aggressive blood pressure reduction, 120.
coupled with 100 or home blood pressure monitoring to make sure that you do not overtreat, and all the other things. I wouldn't investigate nocturnal blood pressure in this patient. I don't need that.
Now the question is, I mean, this patient doesn't have masked hypertension, he has hypertension.
Yeah.
Okay? And is at high risk. So the question is, academic question would be, if there's a patient, for whatever reason, you do 24-hour blood pressure, even though the blood pressure in the office was normal, right? Then you could argue he or she has masked hypertension. So what the guidelines say, it's an option for treatment, recommendation class 2, because there's no evidence, no randomized control trial, to do that. And most of the individuals, I would treat any patient with masked hypertension,
He may have masked hypertension because you didn't confirm office blood pressure.
Okay.
So if you have
Well,
proper
what's the likelihood that this patient has a masked hypertension? It's close to 0, I would guess. Yeah.
I don't need ambulatory monitoring for him.
Yes.
But even if he has nocturnal hypertension, which is quite possible, what did you do? You'll aggressively treat office blood pressure and home blood pressure. In nocturnal hypertension, it's amazing that everybody knows that. It's very difficult to diagnose because if you say you did that, I'll tell you, you have to repeat. You can't diagnose nocturnal hypertension with a single 24-hour blood pressure recording. So you need it twice. Who's going to do that? If you are in the university, in my center, yes. So it's something we can't deal with, and for this patient, it is a secondary question.
And most of the patients, I personally would I treat almost every patient, if possible, in the morning. I even would not consider to give drugs in the evening. First of all, as you mentioned, really needs to be sleep. The sleep profile is very important when you have the patients with nocturnal hypertension, and the confirmation, as you mentioned, is also an issue. Yeah. Long-acting drugs, of course, we use single pill combinations. Good drugs not losartan. We can discuss about losartan. And long-acting drugs. And the major driver is amlodipine, also is in a combination, or like a long-acting diuretic like indapamide, better than hydrochlorothiazide.
Of course.
In a single patient, you even treat in the morning with these combinations.
Déjeme hacer un breve resumen, ya hay más preguntas. La pregunta que hace el doctor Pirscott es ¿qué vamos a hacer si el paciente tiene hipertensión nocturna, que es frecuente o muy frecuente en los pacientes diabéticos? Y en relación al caso que estamos revisando, la respuesta de los profesores es, bueno, necesitamos ser agresivos en el tratamiento, incluyendo si tiene la presión arterial nocturna elevada. ¿Qué vamos a hacer? Pues vamos a darle un tratamiento enérgico que le cubra lo mayor posible las 24 horas de acuerdo a la estratificación de riesgo. Es a brief summary that you say in order to communicate that.
Very short comment. I want to give you my congratulations about this master plan because you know that some years ago when all the guidelines went out, we were speaking about the possibility of having the idea what the guidelines were saying. So I think this is a very important tool to make it easier for the ones that are responsible for treating these patients to get it easier and to get it in a very useful way. That's why I want to congratulate you because I think this is a very helpful tool to make blood pressure control really available.
Okay. So, ¿aquí hay otra pregunta? Gracias, Miguel.
Yes, thanks and congratulations for your talks. And I want to know why is the importance to remark in the slide if you are using a long time drugs. Did you remark in your slide specifically the one pill in the morning? Why in the morning?
2 reasons. First of all, We know from the two studies, the most important is the time study from the UK.
Yeah.
It doesn't make a difference in terms of outcome in the morning or the evening.
Exacto.
So you could do either one. But we recommended to do it in the morning because we know that adherence is better in the morning, 25% better. Professor Bonnier from Switzerland is an expert on this. That's the first reason, and also some tolerability is better. Even of course, the diuretic in the evening for this patient, we need a diuretic in combination with triple therapy. I would guess. Even the amlodipine has some diuretic effect, short effect in the evening. So those are the two reasons. But you can do in the evening. You can do it in the evening. We put it in the brackets, preferably in the morning. But you can, he suggested even in the afternoon. The most important thing, or the late afternoon. The most important is the adherence. Take it once per day, every day. That's the most important. But we know in the morning it's the tolerability, adherence is better. That was the reason. It's an expert decision. The evidence tells us now it doesn't make a difference in terms of outcome.
Okay, thanks.
May I have a comment, please?
Yes.
Don't worry.
And then,
Oh, thank you. Thank you. That's quite interesting, this, because this concept of the time of chronopharmacology is a beautiful concept, but it's not sustainable. Because if the patient is taking chronically a drug, really the next dose is only to maintain the level. So it's, I think it's not simple. And now we have proved that this idea that you have to take the pill in the night is not real. And the main reason to take a pill in the morning is compliance, is adherence. That's the main situation. So it's very difficult to sustain the idea of this chronopharmacology.
en nosotros decimos, a la hora que sea, pero que se la tome, ¿no?
Yes, of course. For the first 2 or 3 days, it's okay. But if we take the decision for a year,
A ver.
So the answer is we don't know. And the time study was the wrong study to tell us. For example, as a follow-up to your question, we know that nighttime blood pressure is the most important in terms of association with risk. We know that for 25 years. But we don't have any study which treated these patients with high nighttime blood pressure. The time study treated everybody in the morning versus evening. Who wants to know that? We used to give the drugs in the morning because all the studies did that. And then we had another study who gave that in the morning or the evening in everybody. But this was not our question. Our question is, those people who have elevated blood pressure at night, do they benefit for bedtime dosing? We don't know the answer.
Professors, the microphones are difficult, Professor Stergiou is a very good friend, therefore I can also argue with him and contradict him, to clarify. The time study was a very, very important study. Unfortunately, we had to do that study with academic public money because there was a study proposing that nighttime will reduce per se the risk by almost 50%, which this study, I personally believe, was an artifact. That was in the literature and was overscored. So the time study was very important to clarify in all patients whether morning or evening there's a difference, and there's no difference. But he's absolutely right. The study did not tell us specifically whether nocturnal hypertension, that was possibly also your question. That cannot be answered by this question, but it's important to clarify, to eliminate the hypothesis that we should even treat all patients at night, which is wrong, right? Yeah, as you mentioned.
This is a quite intuitive concept. If the patient has the blood pressure at night, you have to take the medicine at night. It sounds beautiful. sounds very logic, but always don't follow the logic. If the logic solves everything, why you have to research? Then it sounds very good, but there is no clear evidence that it really happens.
Yes. We have another question from the nephrologist. And just let me say that in Mexico, the adherence, as in the world, is very poor. So we prefer that the patient take every day. I don't know if the morning or if the night, but don't forget take it every day, your pill. You know?
Thank you very much, Martin. Well, let me take you back to Your Majesty, the kidney, of course. And I really would like to say that this is a very interesting patient in the way that you really don't know if it has kidney damage. Which will be your recommendation about this? Will you complete the clinical study of the patient? Or this is a very high-risk patient, so you will say that this patient has kidney failure already? Yeah. What do you say about that?
The eGFR was surprisingly very well preserved, was 80, I think.
80.
So he has is at high risk because of his proteinuria. The dipstick, if you have a dipstick positive, you basically it will reflect hyperalbuminuria according to the on the red as you indicated.
Equivalent to 30,
severely elevated. Yeah. I would, of course, I would still measure UACR to quantify and or to see that and then follow up with the eGFR based on this. And also it has an impact, of course, for the SGLT2 inhibitor. You know, we have diabetes, but also an indication for selection, in addition to the blood pressure lowering drug and SGLT2 inhibitor for this, would be qualifying for this, if you confirm this with albuminuria.
Well, I really would like to say it better. Will you use cystatin C, serum cystatin C, to stratify this patient? Because he has obesity, and this is a very reliable measurement that we can make when you have problems with the body mass. So this is a very important question because in clinical practice and first level clinical practice, they usually do not ask about this measurement.
Unfortunately, I don't know about Mexico. Cystatin C is, in my country, still is very expensive still compared to serum creatinine. And
well, it is expensive
here. But the question is whether it helps you. I mean, all the studies that use the SGLT2 inhibitors now use the CKD-EPI formula.
Yeah, that's right.
And the body mass X was similar to this, the mean body mass. So it works in terms of prediction, in terms of outcome. So I would not need it personally, also for this particular patient. Yeah. So I think CKD-EPI still works even in this body mass index range very well.
I would like to raise another issue. I noticed in the data you showed from Mexico something which is very unusual. You have something like 13% of patients with hypertension who are diagnosed and are not treated. This is rare, which means that many patients in this country have some beliefs. They know that they have high blood pressure and they don't take pills. Yeah. And this fits well with the case you showed that this patient was taking a strange thing for diabetes, that he had low adherence. So what I'm saying here is that we discussed today what are the problems, and we know what is the optimal treatment. So what?
Exactly.
How can we make sure that this patient will do what he has to do?
Exactly.
So we need time to explain to the patient what is the problem and find the way to each individual patient to convince him that he should do what we want him to do, which is not easy.
It's not easy. Estamos de acuerdo. Si involucrar al paciente es fundamental para que esto tenga éxito. ¿Alguna otra pregunta o comentario? Si el doctor Alcocer quiere cerrar con los comentarios finales, final comments.
Thank you very much for your excellent presentation. And well, let me talk with the audience and then I will translate to you. ¿Todos son mexicanos aquí? La mayoría, ¿verdad? Bueno, la mitad de ustedes abandonarán este planeta por causa de la enfermedad cardiorreno-metabólica. Y si le aumentan el aspecto hepático y los otros que tenemos en Macarena, el 60% morirán de esto. Y más de la mitad, porque a mí ya se me pasó eso, morirán prematuramente. Morirán antes de los 75 años. Entonces, inclusive desde el punto de vista personal, más vale tomar en serio esto, ¿no? Creo que no lo tomamos nunca en serio, lo vemos aparte, como si la hipertensión fuera, como si no. El término Macarena es un término que extiende este concepto del síndrome o de la conexión cardio-reno-metabólica, porque se había olvidado cosas muy importantes en esto. Se les olvidó el hígado y en nuestro país es la cuarta causa de muerte en las enfermedades hepáticas. Y pues no se había tenido en cuenta el aspecto del sistema nervioso central. El decaimiento cognitivo es muy importante y está relacionado por lo menos en un 40% con la hipertensión arterial. Entonces, Macarena es un concepto muy importante de vista general. Hemos visto ahora una respuesta muy importante o otra manera de manejar las cosas que propone la Sociedad Europea de Hipertensión, que es MASTER, que también es un acrónimo que nos explica cómo manejar al paciente. Entonces, yo quiero cerrar este simposio pidiéndoles que se conviertan en Macarena Masters, que entiendan la hipertensión como un concepto muy complejo, que lo entendemos como Macarena y que lo debemos manejar con maestría. Entonces, el final de esto, y a lo mejor en algún momento daremos algún certificado en GREHTA, para que se conviertan en Macarena Masters. So I want to say you that I propose that they combine the two concepts, Macarena and Master. And I say that I hope they became Macarena Masters that can make the holistic view of this important problem. So thank you very much. For you. Thank you. Muchas gracias para servir. Muchas gracias para todos ustedes por estar esta noche con nosotros.
Okay, we finish. Thank you very much. Tenemos parroquial communications.
Bueno, pues muchas gracias. Thank you very much, Professor Kreutz and Professor Stergiou. Thank you very much. Bueno, mañana seguimos, les comentaba, empezamos con un desayuno científico, es cupo limitado, o sea, el que llegue temprano, 7:30 de la mañana, va a ser en otro salón alterno y luego acá continuamos con el programa. Mañana también es un día muy, muy, muy bueno, vamos a tener la inauguración, se tuvo que recorrer por cuestiones, ya saben, de la agenda política. La inauguración va a ser a las 12:30 del día. Y la entrega de reconocimientos a todos a las gentes que queremos reconocer aquí de Campeche es a las 3:30, como habíamos quedado. Y bueno, continuamos con el programa. Les quiero agradecer, la verdad, un aplauso para todos ustedes que están a esta hora queriendo aquí. Y pues a los que nos están viendo también en vivo, muchas gracias. Seguimos aquí, tenemos buen rating a pesar del partido de fútbol Pumas Pachuca. No nos quitó rating. Muchas gracias. Hasta luego.
Más Simposio